Good morning, everyone, and welcome to Obesity Week 2021. My name is Kathy Kotz from the University of Minnesota and the Minneapolis VA Medical Center, and I'm this year's TOS president. Due to the COVID-19 pandemic, the last year and a half has been challenging for all of us. I hope all your families are safe and well. It is more important now than ever to stay connected to our professional societies, not only to keep abreast of current obesity science, but to check in with colleagues we have not seen in some time. The state of the pandemic necessitated another virtual meeting this year, but I'm happy to report that we received very positive reviews of the virtual interactive meeting and platform used last year. This year, we took additional steps to make it even better. Next year's meeting is planned to be live and in person, and it will be really great to see you all then too. I'd like to take a moment to cover some highlights of TOS activities over the past year. This slide shows just a few of this year's accomplishments. And as you can see, we've been busy with diversity, equity, and inclusion, which is also the theme of this year's meeting. TOS recognized it needed to improve diversity, equity, and inclusion within the society and to help foster the careers of diverse members, a change which will ultimately translate into better care for all persons with obesity. To this end, we appointed a task force, and I want to thank all the members of this task force, which includes Jamie Ard, Monica Baskin, Michelle Cardell, Tiffany Carson, Jose Fernandez, Shariki Kumaniika, Shalimar Sibley, Fatima Cody Stanford, Tony Camuzzi, Regina Williams, and Shamika Green. These task force members have helped with all these initiatives and strategies. The TOS committees were reinvigorated, balancing diversity. World Obesity Day focus was on COVID-19, obesity, and diversity, equity, and inclusion. And as I mentioned, Obesity Week 21 was planned with special emphasis on diversity, equity, and inclusion. We've also developed proposals to support early career URM, obesity researchers, and a TOS roundtable on health disparities in obesity. These initiatives are designed to bake diversity into the obesity society, and there are plans to ensure these efforts will be sustained. The committees and council have also been hard at work on many aspects of TOS. Some of these efforts are indicated on the slide, but we will hear more about all of this at the business meeting as well. The executive committee and the TOS staff have also been working diligently to ensure that the obesity society is adapting to changes brought on by the COVID-19 pandemic, maintaining engagement with members, starting new initiatives, and ensuring the financial health of the organization. This will all be covered in more depth at the business meeting, to which everyone is invited to attend. I'm going to switch gears now to the upcoming meeting. This year's interactive meeting has been carefully planned by the program committee, led by Jamie Almondoz and his co-chair Kelly Allison. They and the program committee members put in a tremendous amount of work to get an impressive program together. You are going to see the latest science on all aspects of obesity physiology, care and treatment, from the molecule to the bedside to epidemiology and policy. Due to these initiatives, you will be seeing a lot of new faces and new ideas in this year's meeting. I also want to say a big thank you to the executive committee for their guidance of the program, the office staff for their support and incredible efforts, and especially Anita Weiler and Darnella Parks, without whom we would not have this meeting. While I know we all want to see each other soon in person, there are many advantages to the virtual format, including instant roundtables, discussion boards and meeting setups, interactive poster sessions, mentoring, job boards, and the ability to have access to all the meeting programming through the end of the year. But now I will hand this over to the program chair, Jamie Almondoz, to cover these details.
Hi, I'm Jamie Almondoz, chair of this year's program committee, and on behalf of our 32 members, I'd like to welcome you to Obesity Week 2021, our second virtual gathering. The program committee has been meeting since shortly after last year's Obesity Week to plan this year's event, which includes 38 symposia, 12 key lectures, and many other special sessions. Our team has collaborated with over 16 partner organizations to bring you the most exciting and topical obesity science, clinical practice, public health, and policy. This year, we had over 530 abstract submissions that were carefully reviewed by the Science Development Committee, chaired by Paul McLean. These abstracts have been curated by the program committee into 47 orals with live Q&A, 37 on-demand orals, and 369 posters with fun interactive poster sessions. Please make sure to attend and ask questions. This means so much to our young investigators. In addition to this, we're emulating the networking, mentorship, and other collaborative opportunities that occur organically at in-person meetings with the interactive experiences that include roundtable discussions, an NIH listening session, mentorship sessions, idea exchanges, networking events, job boards, a concert, image gallery, and fun activity challenges, to name just a few. As with last year, the more you participate in these events, the more points you earn, which could win you a free trip to Obesity Week 2022 in Atlanta. Putting together a scientific meeting like this takes more than a village, it takes a society. Special thanks goes to this year's co-chair, Kelly Allison, and all the members of the program committee for all of their hard work. Our executive committee team, including Tony Camuzzi, Lee Kaplan, Dan Bessison, Elizabeth Parks, and Leah Wiggum, have been instrumental in guiding the committee and our collaboration with important partner organizations so that we can increase our connections with societies and groups that share our goals. This is my 5th year on the program committee, and I know that none of this would be possible without the tireless work and dedication of our meeting team, especially Anita Weiler and Darnella Parks. And lastly, I want to thank our president, Kathy Kotz, for having the vision to make this year's Obesity Week theme diversity, equity, and inclusion. As an obesity medicine specialist, I believe it is important that we create science, practice, policy, and initiatives for all people living with obesity. And as a gay man in academia, it's important for me to know that I belong to a professional society that values diversity, equity, and inclusion at all levels. Thanks again to all of you for attending. You're really the reason why we're here. And welcome to Obesity Week 2021.
Thank you, Jamie, for all your hard work this year. Your great efforts are going to be evident soon. Now on to the program. The first session is the Presidential Symposium, and we will start by hearing from Nikki Massey, Deputy Director for Digital Marketing Chorus International, who will talk about her story living with obesity. We thought it important to start out with a patient voice because that is why we are here, to better understand challenges faced by individuals with obesity and to strive to provide information and strategies that will lead to better care for all. After this, there will be 6 talks on hot topics in obesity. Each topic represents one of the 6 tracks of the program. First, Rebecca Pearl will discuss health outcomes of internalized stigma among patients with obesity. Then Marianne Danofsky-Kraft will discuss if driven overeating is best captured by food addiction, loss of control eating, or something else. Melissa Chi will discuss eating behavior in coping with COVID-19. Ilya Karatsorios will discuss biological clocks and obesity, a neurobehavioral perspective. Peter Kaczmarzyk will discuss weight loss in underserved patients. And Lisa Miller-Matero will discuss racial disparities in utilization of bariatric surgery and post-surgical weight loss. After these talks, I will present the TOS Presidential Medals of Distinction to 3 recipients and will close by presenting some of my lab's work on central regulation of physical activity in animal models of obesity. Thank you for being here and welcome to the meeting. We hope you enjoy it.
Good morning. My name is Nikki Massey, and I'm so honored to be able to speak to you today about my experience of having received treatment for obesity through bariatric surgery. Now, I'm sure my before story isn't different from many of the stories you hear from patients every single day. I struggled with my weight for my entire life, and throughout my life, my family and I have tried many things to address my weight. I've tried Weight Watchers, I've tried special diets, I've even tried exercise, all to little avail. After having my second child, I had reached my highest adult weight of 330 pounds, which is when I decided to look at bariatric surgery as a possible solution for me. After determining that bariatric surgery was right for me, I underwent the necessary screenings and tests and had Roux-en-Y gastric bypass surgery on January 8th, 2008, which means that as I speak to you today, I'm nearly 14 years post-op. Now, over the year after my surgery, I lost about 70% of the excess body weight that I carried. before I began to regain at the 24-month mark. All in all, I regained about 15% of the weight that I lost, and my weight stabilized there. Since then, I've been able to lead a relatively active life, although not one completely free of health challenges. Like I said, my experience probably isn't that different from those of the stories that you hear every single day. So I thought in our time together, instead of telling you my story chronologically, I would highlight a few points where my relationship with my obesity care providers really mattered and how those relationships affected my health journey. Now, the first thing I'd like to talk to you about is the supports and resources given to long-term bariatric post-op patients. In my experience, after the first few years after surgery, those services and resources become extremely limited. Since my surgery, I've learned that it's actually not uncommon for a bariatric practice to only see patients for a few years after their surgery. My surgeon is willing to see me annually. However, the further out I got from surgery, the more I realized that what I was craving and what I needed was not necessarily surgical follow-up, but a healthcare provider who could provide day-to-day care for me, who actually understood my bariatric body. Unfortunately, my primary care physician just often did not. While we talked about the things like nutritional monitoring through blood work, my primary care physician often didn't understand the types of screenings that I needed at different milestones after surgery. And sometimes my lab results didn't make sense to them, and only really made sense once I employed them to reach out to my bariatric surgeon. I also found that my primary care physician, while well-intentioned, sometimes didn't embrace obesity as a disease and the nuances that that brought along with it. Not intentionally, I think that as a result of that, subtle bias crept in to some of our sessions. Now, as I said, I don't think any of that was malicious, but I do think that my primary care physician just didn't really completely understand how a body with obesity works. And therefore, their follow-up was really the often touted and very often ill-informed and flawed assumptions made about people of size. These experiences put together left me longing for a medical provider who understood me. I've also experienced some gaps in terms of support as a long-term bariatric patient. Years ago, I wrote a blog series on the Obesity Action Coalition website about long-term bariatric patients and support groups. Many of your practices offer very robust support groups with options for non-pandemic in-person meetings, as well as Facebook groups. Those are all really great, but they're often heavily weighted toward pre-surgical or newly post-surgical support. Those supports are really, really needed, but in my life as a long-term bariatric patient, a general lack of support from my surgeon-sponsored support group meant that I often found myself turning to peer groups online for advice, which not only meant that the advice was not based on my medical history, sometimes it wasn't even evidence-based. I would have preferred to go to my surgeon-sponsored support group and ask a member of our professional staff. I wasn't ever told that I wasn't welcome to do so. However, to do so required me to sit through an hour or more of a support group with topics that weren't really relevant to me and where there were few other longer-term post-ops to support or affirm my experience. All of this is to say that bariatric surgery is a powerful tool for weight maintenance. And if I had to go back and make the decision to get surgery again, I absolutely would do it. But speaking as someone who is nearly 14 years post-op, there has to be a recognition that we patients have to actually live in these bodies for the rest of our lives, and that in order to do so, we need ongoing support and resources. In the years since my surgery, I've taken on alopecia, early stage breast cancer, and most recently, iron deficiency. I'm thankful for organizations like the Obesity Action Coalition, which have educated and empowered me to advocate for myself. Those resources closed gaps in my care that would have otherwise caused me problems. My hope in speaking to you today is to empower you to think about how you can help close those gaps for your patients. The bodies of bariatric patients will always be just a little bit different, than the bodies of people who did not have bariatric surgery. And we need your help living the long, healthy lives that we envisioned together with you when we sought out our surgeries. I thank you for your time today, and I look forward to speaking with you during the live Q&A.
Hi, my name is Rebecca Pearl, and I will be speaking today about internalized weight stigma and its associated health outcomes. Weight bias refers to negative attitudes toward individuals who are perceived to have a high body weight or overweight or obesity. Some of the common stereotypes that are assigned to people with a higher weight are that they're lazy, lack willpower or self-control, that they're not intelligent or unattractive. There's blame that's placed on people because of their weight due to a misconception that weight is entirely within an individual's control. So the phrase personal responsibility is often used with the implication that people who are perceived as unable to control their weight are being irresponsible. So there's a moral judgment that's attached as well. And because of these negative attitudes and stereotypes and blame in our society, people with a higher weight are devalued or stigmatized. So this is the discrediting of someone as a person simply because of weight. The internalization of weight stigma is conceptualized as a stepwise process, and this largely comes from research on mental health stigma. So the first step is awareness of weight bias and stigma among people with a high weight. The second step is agreement with the negative attitudes and stereotypes. And the third step is self-application. So someone with a higher weight believing that they themselves are lazy or are to blame because of their weight. And then the fourth step is self-devaluation or reduced self-esteem or self-worth. So this does differ from body dissatisfaction, although it's related, but it goes beyond disliking one's body to disliking oneself as a person because of weight. I'd like to share some examples from patients who I've conducted semi-structured interviews with. And these are all individuals who have reported experiencing weight stigma in the form of teasing, bullying, or discrimination. And they are also all folks who score high on internalization scales. And in response to a question about how weight affects how they think and feel about themselves, here are some of the responses. So awareness of being treated differently because of weight, internalization of stereotypes, blame, as well as self-devaluation, feeling less valuable or worthless because of one's weight. Now, certainly not everybody internalizes weight stigma to this degree, but I do want to highlight those last three responses to emphasize that for many people, weight does affect their everyday lives. Who internalizes weight stigma? Well, estimates suggest that 40% of US adults across the weight spectrum report some degree of internalized weight stigma. We don't have established cutoffs for clinical significance on these scales, but based on population norm data, estimates suggest that 20% of adults and up to 50% of adults with obesity report what might be considered a high level of internalized weight stigma. We have some information about characteristics of people who tend to score higher on internalization scales, so some demographic characteristics. And this is not to say that people who don't fit into these categories don't internalize weight stigma as well, such as men or people of color. And in general, there needs to be more inclusion of diverse groups in this area of research and consideration of intersectionality and how internalization might look different in different groups. Certain types of experiences, especially related to weight stigma, are associated with higher internalization, such as an earlier onset of both having a higher weight and experiencing weight stigma, as well as recent experiences of weight stigma or experiences from close family members or in work settings. These are all associated with higher current levels of internalized weight stigma. And two very recent studies also suggested that adverse childhood experiences might also be associated with subsequent higher levels of internalization. I do want to emphasize that internalization can affect people across the weight spectrum, and this also affects people outside of the US. So most of this research has been conducted among adults in the US, but these are recent data collected from people who were enrolled in a commercial weight management program across 6 Western countries. And you can see that across countries on this 1 to 7 scale, Scores did increase as BMI increased, and some countries, such as the UK, Australia, and France, had higher average scores than countries like the US, Canada, and Germany. What do we know about internalization's associations with health? Well, most of this research does come from cross-sectional observational studies, so we can't infer causality. However, the associations are robust and consistent, so we can have high confidence in a significant relationship, especially with impaired mental health. So we know weight bias internalization is associated with more depression, anxiety, stress, lower self-esteem, greater body dissatisfaction, and eating disorder symptoms, as well as lower mental health-related quality of life, including social and emotional functioning. And this is as measured by global or general measures of quality of life, as well as weight-specific measures. Some research suggests that internalization might mediate or moderate the relationship between BMI and mental health. So in any relationships between obesity and mental health, internalization of stigma likely plays a pivotal role. And some studies have included both measures of experiences of stigma from other people, as well as internalization. And when comparing effects, internalization seems to be the stronger predictor of mental health outcomes. So experiences of weight stigma are certainly harmful, but this internalization might be a key driver of these associated health outcomes. We also know that internalized weight stigma is associated with greater engagement in unhealthy behaviors and less engagement in health-promoting behaviors, especially in eating and physical activity, which are very relevant to weight and weight management. So people with higher levels of internalized weight stigma are more likely to report using eating as a coping strategy, having lower self-efficacy to control their eating, more disinhibited and emotional eating. Among people who are actively trying to manage their weight, less self-monitoring of eating, and poor adherence to bariatric postoperative diet. And for physical activity, we also see internalization associated with lower motivation and self-efficacy, less actual engagement in physical activity, although more engagement in compensatory or compulsive exercise. When people are enrolled in weight management, smaller increases in physical activity among people with high versus low levels of internalization, and less self-monitoring. And again, internalization does sometimes mediate or moderate the effects of weight stigma experiences on these outcomes. So again, highlighting internalization as playing a pivotal role in these behaviors. Now, you might expect that if internalization contributes to psychological distress and unhealthy behaviors, that this would also translate into impaired physical health. There's a lot less research on the associations between internalization and physical health, but some both prospective and retrospective recall data suggest that internalization is associated with less weight loss and maintenance and more weight gain and weight cycling. These effects are mixed and so definitely warrant greater attention. There are also significant associations between internalization and reduced physical health-related quality of life, including things like physical functioning and bodily pain, as measured by both general and weight-specific measures. There's still an open question of whether self-directed stigma is a physiological stressor in the same way that we consider experiences of stigma from other people to be. So there's a handful of studies that have looked at markers of physiological stress and cardiometabolic risk in relation to internalized weight stigma, and have found significant differences in resting heart rate, dysregulated cortisol, and greater odds of metabolic syndrome, even when controlling for BMI, and other health factors, including depression. So several unanswered questions still warrant further research. The first being whether or not internalized weight stigma is a form of chronic stress in the same way that we think of bullying and discrimination as being forms of stress. We need to understand the direction and causality of the relationship between internalization and health, which will require prospective research and creative experimental designs. There's not as much research on how internalization affects children and adolescents. There have been some studies that have adapted adult scales and do suggest harms for youth, but this also requires more attention, as well as how we might best measure internalized weight stigma, especially to make sure we're capturing the experiences of diverse groups and to work toward developing a cutoff for clinical significance. I'll end by briefly mentioning some strategies for preventing and reducing stigma and how they might affect internalization. So at the structural level, we can think about laws and policies to prevent weight discrimination, media guidelines to reduce stigma in popular media and news, and trainings for people in institutional positions of power, such as educators, employers, or healthcare professionals. And we want to study how these interventions affect experiences of weight stigma and also how they might trickle down to affect internalization. At the interpersonal level, we might think about how campaigns to reduce public stigma could change the culture and also affect internalization. And for people who have already internalized stigma at the intrapersonal level, how might interventions like peer support or psychological counseling help to reduce self-devaluation and also potentially improve health outcomes that are associated with internalization? So in sum, weight stigma and its internalization are highly prevalent, including for people across the weight spectrum. Internalized stigma is associated with impaired mental and physical health, but more work is still needed to understand the mechanisms and the effects, particularly on physical health, as well as how to effectively intervene. Thank you for your attention, and I look forward to the Q&A.
Thank you for the opportunity to speak, and many thanks to Dr. Kotz and the Planning Committee for inviting me. I was asked to speak about two constructs representing driven overeating. So I thought I would begin with some definitions. Food addiction has been defined as an addictive-like eating phenotype marked by diminished control over consumption and repeated failed attempts to control intake. Loss of control eating has been defined as a subjective experience of being unable to stop or control eating regardless of the amount of food consumed. As I'm sure you have picked up, at the core, both terms share the key component of reduced control over eating. And this is likely the key component of driven overeating. And driven overeating is studied around the globe, but in different languages with different nuances. For example, research groups are focusing their efforts on a variety of distinct but likely overlapping constructs, included but not limited to stress eating, reward-based eating, power of food, poor impulse control, and the list goes on. In my neck of the woods in Bethesda, Maryland, we have been studying many of these constructs, but most of our data have been in the language of loss of control eating. In almost 2 decades of research, our group and others have found that the correlates of loss of control eating in children and adolescents include high weight and adiposity, decreased heart rate variability and increased heart rate, which are indicative of a stress response, metabolic syndrome components, elevated fasting leptin, genetic and neural underpinnings, objective consumption of highly palatable foods, for example, desserts and snacks, mood symptoms, difficult psychosocial functioning, and other driven overeating constructs. Outcomes adjusting for relevant covariate predictors such as initial weight and weight gain over time include excessive weight and adiposity gain, worsening of metabolic syndrome components, increases in depressive and anxiety symptoms, and development of partial or full syndrome binge eating disorder. Based on these data, we propose targeting loss of control eating to prevent excess weight gain. We hypothesized that if we could reduce loss of control eating, we might be able to reduce the excess weight gain and adverse outcomes attributable to the behavior. However, this proposal, when carried out in a randomized controlled clinical trial, resulted in equivocal outcomes. Specifically, results demonstrated reduction in loss of control eating and prevention of excess weight gain in both an experimental intervention and an attention-only control group. In addition, remission of loss of control eating produced improvements in metabolic syndrome components regardless of group assignment. However, targeted subgroups based on demographic or psychological characteristics, such as older age or higher anxiety, were more responsive to intervention. I should mention that we are in good company. Other groups targeting other driven overeating behaviors has yielded similarly mixed findings. This has led us to ask, why are we missing the mark? Is it possible we have all been studying the same or very similar driven overeating phenotype? To answer this question, I think it is time to work together. We can all agree that driven overeating appears to be a potentially important behavioral phenotype. And psychological weight management approaches have typically focused on talk therapy, targeting behaviors. However, driven overeating behaviors as currently measured may not be precise enough. To this end, mapping behaviors to underlying physiological source producing driven overeating patterns may yield improved outcomes. Thus, we have wondered, might neural endophenotypes provide greater precision for targeted weight management therapies among those with driven overeating? If we define driven overeating as a term that involves reduced control over eating, this central component is likely present in most, if not all, constructs being studied. In the field of psychology, we often study behaviors and traits in the context of the brain. Thus, it is not surprising that driven overeating has often been studied in the context of neural networks. Some are studied as a response to or precursor of negative mood or affect. Some are studied as a reward response, and some in the context of executive functioning, such as decision-making. To this end, we have proposed that linking driven overeating constructs to underlying neural networks as a first step to determine phenotypes that will more consistently predict outcome and intervention response. For example, networks involving negative affectivity may link to emotional eating due to anxiety, depression, or stress. Those involving reward responsivity may link to attentional biases to food cues or relative reinforcing value of food. And executive functionings may map onto impulsivity or poor self-regulation. In addition to identifying groupings based on networks, our expectation is that these groups will likely interact to produce driven overeating and risk for excess weight gain. Should this proposal be supported, we can then develop interventions that target the most prominent driven overeating grouping. For example, if driven overeating is in response to negative affect, psychotherapy to improve mood, such as cognitive behavioral therapy or interpersonal psychotherapy, may be considered. Appetite awareness training might be useful for those with reward-related eating. Executive functioning training might be useful for those with deficits in the area of decision-making. Or, as may be the case, therapies for interacting groups may be indicated. For example, emotion regulation therapies would improve both mood and decision-making for those who present with eating in response to negative affect and impulsive decision-making. I want to be clear that these ideas are not novel. They have been informed by other proposals. For example, over the past decade, Research Domain Criteria, or RDoC, for mental disorders has proposed studying units of analysis to group constructs by domains, including negative valence, mapping on to negative affect, positive valence, which may capture reward-based eating, and a cognitive domain that will link to executive functioning. In addition, matching medication and other intervention approaches to phenotypes has been proposed for obesity treatment. For future research, I would like to see us join together to match reported and observable behaviors to physiological drivers. If such a proposal is supported, matching driven overeating grouping to therapy may be especially useful for prevention of excess weight gain and adverse outcomes, and provide avenues to bolster other approaches, including, but not limited to, medication, brain stimulation, and surgical treatment. Clinical implications may involve more thorough assessment of the range of driven overeating prior to intervention recommendations, and more precise interventions to improve outcomes. I would like to acknowledge my colleagues, particularly my primary collaborator, Dr. Jack Yanofsky, and I would like to thank you for your time and attention.
Hello, everyone. Thank you for joining our session. I will be continuing the conversation on factors impacting eating behavior and share a study we implemented during the COVID pandemic to understand psychosocial factors that mediate stress-related eating and how this could impact our food choices. My group is located in Ottawa, Canada, and in spring 2020, we, like many in North America, had experienced sudden stay-at-home orders intended to curb the spread of COVID-19. And during this time, when many people were cooped at home, you may recall that there was a surge in reports of quarantine baking, and we found that there were shortages in flour and other baking supplies in the grocery stores. It appeared that this might be a form of coping with the stress related to the pandemic, and this prompted us to ask if whether or not such quarantine baking activities might have also implicated a shift in eating habits and food choices. When our team started this study, we were seeing emerging studies from Europe where the spread of COVID had started sooner than it did in Canada. There was one study that reported healthier eating, actually, because of reduced access to fast foods and because they were preparing meals at home more often. However, the vast majority of studies that had emerged showed that individuals displayed unhealthy eating habits during the lockdown period. So poor eating habits could have significant negative impact on metabolic disease. And during the course of the pandemic, about 1 in 5 adults reported gaining up to 10 pounds. And this was more prominent in participants living with obesity. Now, given that about 2 in 3 adults in North America are overweight or have obesity, a sustained period of poor eating could tip the scales for many people. And this became even more concerning during the pandemic because although having obesity did not increase the risk of being affected by COVID-19, obesity and its comorbid diseases like diabetes and hypertension greatly increased the risk of COVID-related complications should one get infected. So for example, individuals with obesity are more likely to require intensive care or the use of a ventilator. So we wanted to see if the trends in food choice observed in Europe would also be present in Canada and the United States. And so we implemented an online research questionnaire to survey participants living in Canada and the US to understand what COVID factors could contribute to the shifts in food choice. And secondly, to see what is the relationship between stress and eating to cope. This study was called The Piece of Cake and was coordinated by a really talented undergraduate student, Nikita Kozioli, and my collaborators, Dr. Jaime Anisman and Dr. Kim Matheson, both at Carleton University as well. So the survey included a collection of questionnaires and scales that asked about participant demographics and also their COVID-19 experiences, their food choices over the course of a week, their mood at the time, and how they appraised or coped with stress. We were able to recruit 680 participants, and the majority of our participants were female and quite young, so under the age of 30, and they mostly had a normal body weight BMI. The majority of participants also had some form of post-secondary education and were living in a household with above average household income. However, none of these demographic parameters had contributed to the outcomes that I'll be showing you on eating behavior. So the data I collected, or that we'll be discussing here, was collected between May and June 2020. But despite being in the first wave of the pandemic, we did not obtain many participants. Just 7% were actually infected by COVID. And this amounted to less than 50 participants who were infected or were close to somebody who was diagnosed. Almost all of our participants were living in a city that experienced a stay-at-home order. And more than 3/4 of these participants had to switch to working from home. However, we did note that 40% of participants experienced an employment change status. And an employment change could involve working more hours than usual, working reduced hours, or in fact, they may be laid off. So we noticed also that those who worked reduced hours and were laid off were more likely to be younger or lower income individuals. Now, experiencing employment change required more coping resources. Particularly, coping mechanisms could be avoidant, so avoiding the problem, emotion focus, where we cope with our feelings, and problem focus, so coping by executing a problem-solving strategy. So how an individual appraises their situation is also related to the coping strategies that they would choose. So appraising a situation to be very stressful, typically individuals would be using avoidant or emotion-focused coping strategies. Meanwhile, appraising a situation to be completely within their control, or at least within their control, so controllable, would be more related to using problem-focused coping mechanisms. When we controlled for these stress appraisals, the relationship between employment change and coping was diminished. And thus, appraising a situation to be stressful actually mediated the relationship between employment change and the coping strategies chosen. And meanwhile, although appraising a situation to be controllable is related to coping, it did not mediate the relationship between the employment change and the coping. Now, predictably, experiencing employment change was also related to mood. In particular, being laid off was most associated with more poor mood and less positive mood. However, it was the coping strategies that were stronger predictors of mood. So positive mood was predicted by using problem-focused strategies of coping, whereas negative mood was more predicted by emotion-focused or avoidant coping strategies. Interestingly, negative mood was associated with the consumption of comfort foods, whereas positive mood was associated with eating healthy snacks like fruits or vegetables. Based on these correlational analyses, we see associations between mood states and coping on food choice, and we next determine what mechanisms might underlie these effects on food. So negative mood predicted the intake of sweet and salty snacks, but not of wholesome snacks, which was predicted by positive mood. Specifically, eating to cope was associated with comfort eating, but not of healthy snacking. The hierarchical regressions we performed show that eating to cope, which is a form of emotion-based coping strategies, mediated the relationship between mood, our affect, and food. In fact, negative mood was more likely to trigger coping by eating, and hence comfort food intake. Meanwhile, positive mood predicted less eating to cope. So in summary, we found that employment change and shifting to working from home were significant COVID-related stressors and factors, and that led to worsened mood and mental health outcomes, especially when dealing with the situation using emotion-based coping strategies. Consequently, we found that eating to cope actually mediated the relationship between poor mood and unhealthy snacking. In addition to eating, we are now also analyzing the role of physical activity as a counterpart to healthy living. We rolled up follow-up surveys with our participants to assess physical activity levels 6 months into the pandemic period. We found that physical activity levels actually decreased over time. And importantly, this decrease is related to how we appraise the stress of our situation, whether we appraise, especially when we appraise the situation to be threatening or uncontrollable. This decrease in physical activity actually negatively impacted mood and depressive scores. So we now want to know if this could have downstream consequences for eating behavior. We have planned prospective studies to understand whether these trends would reverse as restrictions are loosened and our communities can begin to recover from the pandemic. So we have observed that poor food choices and reduced physical activity are indirect impacts of the pandemic that can be detrimental to overall health. In closing, just as government agencies have advised citizens to adopt public health measures to ward off infection, we believe that this is also important to consider mental health considerations because they can have major impact on our physical health. Finally, we hope that our work would help advocate for the availability of social support resources that would be essential for coping, building resilience, and facilitating recovery. Thank you so much for your attention.
Hello, my name is Ilya Kratzareus. I'm an associate professor in psychological and brain sciences at the University of Massachusetts in Amherst. And I want to thank the organizers for inviting me to come and give this presentation today, talking about biological clocks and obesity. Just a quick thank you to all the funding agencies that make all of our work possible. Circadian or daily rhythms are ubiquitous in physiology and behavior. This is just a little example of some of the key rhythms that several people in the audience might be very interested in. But the point is that rhythms are present in every single kind of measure that we'd like to assess. And these circadian rhythms are driven by circadian clocks throughout the brain and the periphery, but there is a central brain clock in the suprachiasmatic nucleus of the hypothalamus that is the key driver of these rhythms and takes information from the external environment, primarily light, and uses that to synchronize these various clocks. We know that disrupting clocks can really negatively impact health in a variety of ways, both behavioral and mental health, as well as physiological well-being. One of the major things that we know is affected by circadian and sleep disruption is metabolic function. And in this review paper by F.N. Cowder back now in 2008 shows the clear correlation between the decrease in sleep that we've seen in the population and the increase in obesity rates. My lab is particularly interested using animal models, and all the data that I'm going to share with you today comes from C57 Black 6 male mice. We use animal models to understand how disrupting this brain clock then can lead to effects both in the periphery and in the brain, and what this might mean for behavior. The talk is split into two short parts. The first part is summarizing some of the work we've done understanding the role of circadian desynchronization on metabolic function. And the second part is focusing on brain function and how this circadian desynchronization might drive changes in brain and behavior. The method that we use to alter circadian rhythms and cause circadian desynchronization, or CD, as you'll see throughout the rest of this presentation, is by changing the light-dark cycle from the standard 24-hour, 12 hours of light, 12 hours of dark cycle to a 20-hour light-dark cycle, 10 hours of light and 10 hours of dark. And what this does is it drives changes in underlying physiological and behavioral rhythms, effectively pulling them apart and desynchronizing them from each other, and also in some cases leading to a really significant decrease in the overall amplitude. We see this very clearly in the periphery using a mouse model that allows us to visualize the activity of one of the core clock genes, period 2, by measuring light generated by the expression of luciferase. Here, what we're doing is a very talented former graduate student, Derek Phillips. His experiment here was to take these mice and image them over the circadian day, either under control conditions or circadian desynchronized conditions, and see how their liver rhythms have changed. And what you're seeing here is a very pronounced change in the normal circadian rhythm of per activity in the liver to this very abnormal altered amplitude and altered peaking of circadian activity in the liver. Importantly, this is associated with some pretty clear metabolic outcomes. I'm only showing you two things here that are quite gross measures. And the first is a pretty significant increase in body weight from animals housed under circadian desynchronized conditions, as well as an increase in adiposity. But we also see high levels of insulin, high levels of leptin, high levels of plasma triglycerides, changes in feeding behavior, changes in respiratory quotient. So a lot of things are being affected by the circadian desynchronization protocol. What I next want to get at is to try to understand now how we go from the effects in the periphery to some effects in the brain, and eventually potentially how these are linked together. What we have found with our circadian desynchronization paradigm is that doing this light-dark cycle manipulation results in several different behavioral phenotypes. One of the behavioral phenotypes is increased cognitive rigidity, or inability to show cognitive flexibility or update existing information in one's memory. In this task, we use a modified Morris water maze where the mouse has to navigate through this pool of water to navigate to a hidden platform. And what I hope you can see is that when we do this task with these animals, that both groups, control and circadian desynchronized, learn the task very, very well. And then what we do is we conduct a reversal trial where we take the platform and move it from one side of the maze to the other. And we see that in both groups, there is impaired performance on the task. But then what happens very quickly is that on the very next day, we see that the control animals have now learned the location of this new location of this platform, whereas the circadian desynchronized animals are still lagging behind in their ability to update their information of where this new platform is. And they do this because they're making a lot of errors where they continue entering the old quadrant of the maze to where the platform used to be rather than the new quadrant of the maze. We've also found differences in different kinds of exploratory or anxiety-like behaviors. What we find in this light-dark emergence task, where the animal's housed in a dark covered area and I'm then allowed to explore a slightly more large and very brightly lit area, which models how much risk the animal is willing to take, broad strokes, of course. And what we see is the circadian desynchronized animals are leaving the safety area much more frequently than control animals, that they do this much more quickly. And it's not just because they're more active and they're hyperactive in doing these things. They have about the same level of activity. We have similar findings in other kinds of open field behavior. You can take a look at the paper that we published now almost 10 years ago to explore some of these effects. Importantly, both cognitive flexibility and behavioral inhibition, as I'm explaining here, involve the prefrontal cortex. What we find remarkably in these animals that are circadian desynchronized is that pyramidal neurons in the prefrontal cortex show significant changes in overall morphology. The cells actually get smaller and less complex. And what you're seeing here is a measure of apical intersections. So basically the complexity of the apical dendrite coming off of this neuron. And what you can see is that the circadian desynchronized animals have much less complex dendrites. We again have many other measures that we've taken in this regard. And you can again be noted to take a look at that paper for more information there. Importantly, though, we've also started to explore, given our metabolic effects in the periphery, we've also started to explore metabolic effects centrally. What I'm showing you here is just a real thumbnail sketch of the way that neurons actually get a lot of their energy via the lactate shuttle that shuttles glucose from the bloodstream via astrocytes and converts it into lactate that is then used by the astrocytes to basically feed neurons to allow them to generate the energy that they need to maintain all of their different functions. We can actually measure this extracellular lactate using implantable biosensors, which is just what Naomi Wallace, a very talented graduate student in the lab, was able to do. And what she was able to find was that there's a very beautiful rhythm of extracellular lactate in the prefrontal cortex of control animals. And we can see that this is persisting even in constant conditions, really clearly showing this is a circadian rhythm and not driven by the light-dark cycle. But remarkably, what she found was, again, similar to our effects in the liver, that this metabolic activity is significantly blunted in circadian desynchronized animals. And this is also shown even more significantly under constant darkness conditions, where we see really no rhythm whatsoever in these animals. So this is very interesting, because now we have this link between changes in the overall structure of the neurons, but also potentially in some aspects of function. And to probe that more closely, a really talented postdoc fellow in the lab, Dr. Brandon Roberts, has explored using patch clamp electrophysiology changes in biophysical properties of neurons in the prefrontal cortex. What he found was that under normal conditions, PFC's pyramidal cells show very nice rhythm in many different aspects, but including the resting membrane potential, showing that they are hyperpolarized in the nighttime, or the animal's active phase. And again, remarkably, what he found was that following circadian desynchronization, or environmental circadian disruption, as we call it here, these neurons show a significant decrease in their firing frequency, suggesting that we have a pretty fundamental change in the function of these neurons in the prefrontal cortex. And so to conclude, what I hopefully have communicated today is that disrupting the circadian clock can drive changes in brain, behavior, and metabolism, that metabolic pathways in both the periphery and the brain are involved, which possibly suggests a common link at the mechanistic level, how these things might be occurring. And understanding the contribution of the metabolic disruption to these changes in neuronal dynamics is really, really critical. I'd like to thank the entire team who has worked on this. Dr. Roberts is getting ready to go in the job market soon, so please pay attention and see if you see his application cross your desks. He's a really great scientist. I want to thank all the other students that have worked on this project. And if anyone has additional questions, I'm more than happy to engage via email. Thank you again for your attention.
Hello, everyone. It's my pleasure today to be here to discuss our research on weight loss in underserved patients. My name is Peter Kaczmarzyk, and I'm from the Pennington Biomedical Research Center in Baton Rouge, Louisiana. As we all know, obesity affects a significant portion of our population. You might also know that CMS reimburses for intensive behavioral therapy for obesity. However, in 2012 and 2013, less than 1% of beneficiaries availed themselves to this service. Therefore, we need to explore other treatment models based on the obesity guidelines and adapted to real-world settings. The PROPEL trial was one such study. It is promoting successful weight loss in primary care in Louisiana. And the primary aim of PROPEL was to develop and to test the effectiveness of a 24-month, patient-centered, pragmatic, and scalable obesity treatment program delivered within primary care, inclusive of an underserved population. A hallmark of the PROPEL trial was its extensive patient engagement. Prior to conducting the trial, we hosted several focus groups around the state of Louisiana to better understand obesity treatment options in primary care. Following that, and throughout the course of the trial, we had 3 patient advisory boards, which each met quarterly throughout the trial. And these patient advisory boards helped us in a number of ways. Number one, they named the study, and they also advised us on patient recruitment, patient retention, as well as helped us interpret the results of the trial. It was very invaluable for the investigators. PROPEL is a cluster randomized trial, meaning that we didn't randomize individual patients, we actually randomized clinics. So we randomized 18 primary care clinics across the state into either usual care or into the intensive lifestyle intervention. From there, we recruited 351 patients into the usual care arm and 452 patients into the intervention. And of course, all of these patients had to be patients at these clinics that were participating in the trial. Now, the intensive lifestyle intervention arm was adopted from the Diabetes Prevention Program and the Look Ahead studies. Patients received weekly counseling sessions for the first 6 months, followed by monthly sessions for the remaining 18 months. Now, all of these sessions were delivered by health coaches who are actually embedded within the primary care clinics. They were part of the primary care team. The health coaches had a variety of tools available to them, including portion-controlled foods and daily weighing. So we encouraged daily weighing in all of the patients, and we gave them a digital scale to take home. From that, we were able to plot their weekly weight loss, or daily here, throughout the trial, and we could monitor their adherence to the intervention. And if a patient got out of their zone of adherence, if we saw them start to fall off, we could therefore intensify the intervention quite rapidly and get them back on track. So this is one of the key features of the Propel intervention, was daily weighing and tracking of their weight by both the patient and the health coach. Now, the usual care group, they received routine care from their primary care team throughout the trial. We also sent them 6 newsletters over time covering different health-related topics and providing community resources. This was important to keep them engaged in the trial and to keep them coming back for their assessment visits. So patients in both the usual care group and the intensive lifestyle intervention, they had their assessments measured at baseline and at 6, 12, 18, and 24 months throughout the duration of the trial. So our results were published almost exactly 1 year ago today. And so I'm going to try to review some of these key findings with you right now. So, we've been talking a lot about underserved patients. I'd like to just provide some patient characteristics at baseline in our sample. We had 803 patients enrolled in the trial with a mean age of about 49. 67% of the sample was African American, and 41% of the sample had mean or their total family income below $20,000 per year. 31% of the sample had low health literacy, and 31% of the sample was food insecure. So now, with this background in mind, let's look at some of the results. Now, the primary outcome in Propel was the percent change in body weight from baseline. And we see here in the usual care group, in this left-hand column, that they lost on average about 0.5 percentage point of body weight, which they kind of maintained throughout the trial. On the other hand, the intensive lifestyle intervention lost about 7% body weight by 6 months. And out as far as 24 months at the end of the trial, they had maintained an average of 5% weight loss. This right-hand column shows you the difference between the usual care and intervention groups. And we see that at 24 months, relative to usual care, the intensive lifestyle intervention produced 4.5% of weight loss on average. We also modeled change in body weight in kilograms, and we find very similar results here. On average, the sample was 100 kilograms in weight at baseline, and that's why these changes in body weight are very much reflective of the changes in percent body weight. Finally, we also looked at change in waist circumference, and we see that by the end of the trial, the usual care, adjusted change in waist circumference was about 5 centimeters. So these patients had maintained about 5 centimeters in reduction of their waist circumference at 2 years into the intervention. I'd like to focus on the race-specific results just for a moment. Here we see a plot of percent weight loss. In the black lines are the African-American patients. The solid lines at the top are the usual care group, and the dotted lines are the intervention group. The red color represents other races, primarily white in this case. And we see here that, throughout the intervention, the African-American patients lost less weight on average than other races. And we have a paper that we're working on right now trying to describe these differences and some of the reasons for them. So we also wanted to look at dichotomous outcomes. For example, the percentage of patients who achieve 5 and 10% weight loss. And right here, I'm showing the results at 24 months. And we were quite encouraged to see that approximately half of the sample in our intensive lifestyle group maintained 5% weight loss at 24 months. It was also encouraging to see that approximately 1/4 of the sample had maintained a 10% weight loss at 24 months in the intensive lifestyle intervention. And you can see the comparisons here to usual care. So we have a large focus on food security as a social determinant of health and a key factor in obesity, particularly in Louisiana. And so Dr. Candace Myers in our group has analyzed the effects of the weight loss intervention as it relates to food security. And so in this graph on the left-hand side, we see the black lines are patients who are food insecure, whereas this teal line are patients who are food secure. And we see there's no difference in usual care. However, in the intensive lifestyle intervention, we see that individuals who are food secure lost more weight over the course of the trial. So in a sense, food insecurity blunted the response to the weight loss intervention. And Candace is further exploring this now. So in conclusion, we understand obesity is a significant public health concern, especially in underserved populations. However, clinically significant weight loss is possible among low-income primary care patients, as long as you take this intervention to where it is needed, both the location as well as where the patients are in terms of preferences, attitudes, and their culture. So thank you very much for your attention. I'd like to acknowledge the large staff and investigator group that we had working on Propel, and finally also acknowledge our funding, which was primarily through PCORI as well as the NIH. So with that, I'd like to thank you for your attention.
Hi, my name is Dr. Lisa Matero, and I am a clinical health psychologist and assistant scientist at Henry Ford Health System in Detroit, Michigan. And my area of research looks at patients who are undergoing bariatric surgery with a particular focus on mental health, substance use, and weight loss outcomes. And I also have an interest in looking at disparities amongst these patients as well, which is the topic of the talk today. So as you likely know, bariatric surgery is the most effective treatment for patients with severe obesity, both in terms of long-term weight loss outcomes and co-occurring medical conditions such as diabetes. The number of surgeries that are being performed in the United States have been growing rapidly over the past decade or so. Since 2011, the number of surgeries has grown about 62%, with 256,000 surgeries that were performed in the United States in 2019. The most common procedures that are performed in the United States are the sleeve gastrectomy and the Roux-en-Y gastric bypass. Although there are these growing numbers of patients undergoing surgery, only about 1% to 2% of patients ultimately do undergo surgery. So there is a huge missed opportunity for patients because of the low utilization rates of bariatric surgery. And not only are utilization rates low amongst the general population, but these utilization rates are also even lower amongst underserved patients. And so quite a bit of research has looked at patients undergoing bariatric surgery, and across many studies, patients undergoing surgery tend to be white, tend to be women, and tend to be individuals with private insurance. And I was interested in specifically looking at those pursuing surgery in Henry Ford Health System, which is in an urban location in Detroit, and we have a high prevalence of racial minorities. And so we looked just across the board of those who had started the process to get worked up for bariatric surgery to see if that disparity was still there. And although we do have higher rates of Black patients who start the bariatric surgery process, the majority still tend to be Caucasian, despite our high numbers of Black patients across the health system. And we also started to look at, of those who start the bariatric surgery process, who experiences attrition or what factors are associated with attrition. And so one of the studies we looked at how race and socioeconomic status may influence attrition to surgery. And so in univariate analyses, we found that patients with private insurance, patients who did not endorse being on Social Security disability, higher incomes and white patients tended to have higher odds of undergoing surgery. In a multivariate analysis, we found that the variables that remain statistically significant in predicting who undergo surgery tend to be patients who are white and patients with private insurance. So again, we're seeing that patients, Black patients and patients with lower socioeconomic status may be not only less likely to start the bariatric surgery process, but may also be more likely to experience attrition to surgery as well. And we do have a paper that's under review right now that started to expand upon this and looking further at sociodemographic factors, psychological factors, and eating behaviors for patients who are starting the bariatric surgery process. In this particular sample, approximately 2/3 of our patients at Henry Ford Health System who started the process did ultimately undergo surgery within about 2 years of starting that workup process. And then amongst those who experience attrition, we were curious to see, again, factors that are influencing attrition. And while lower rates of men are starting the bariatric surgery process, we also found that men have a higher rate of attrition compared to women. So 42.6% of men experienced attrition to surgery, whereas only 31.7% of women experienced attrition. And then looking at specifically among men and among women, what factors might be related to attrition to surgery. Race was one of the predictors. So white men had about 2 times the odds of undergoing surgery compared to Black men. And one of the eating behaviors we looked at was food addiction. And for men without food addiction, they had 2.67 times the odds of undergoing surgery compared to men without food addiction. Amongst women, in a multivariate analysis, we also found that race was a significant predictor with an odds ratio of 3.16. And women without a history of binge eating were also more likely to undergo surgery, again, with the same odds ratio of 3.16. And not only are there disparities in who undergoes surgery, but there are also disparities in weight loss outcomes. Across a great deal of research has really suggested that racial and ethnic minorities do have poor weight loss outcomes. And we also found that this is the case within our patient population at Henry Ford. And we were looking at socioeconomic predictors of weight loss outcomes, 1-year weight loss outcomes after bariatric surgery. And we found that those with a higher median income and white patients tended to have better weight loss outcomes. And in a multivariate analysis looking at income and race, we found that race remained to be a significant predictor of weight loss outcomes, such that white patients are having better weight loss outcomes than our Black patients. So we're starting to get into, okay, why does this disparity exist? And there are a couple of hypotheses that we wanted to look at. The first is, can this disparity in weight loss be explained by procedure type? So we do know that patients who undergo Roux-en-Y gastric bypass tend to have better weight loss outcomes than patients who undergo sleeve gastrectomy. Another hypothesis is pre-surgical BMI. There also is research to support that patients who start the surgery process at a higher BMI tend to have poor weight loss outcomes. So maybe it's possible that Black patients are undergoing sleeve gastrectomy at higher rates, or maybe are starting at higher BMIs, and this could potentially explain the weight loss disparity. So we looked at this within our patient population at Henry Ford, and we found that race was not related to surgery type or to pre-surgical BMI. So unfortunately, that wasn't an answer to our question. But we did look at weight loss outcomes within surgery type. So we did find that disparity amongst patients who are undergoing Roux-en-Y gastric bypass. So our Black patients did have a poorer percent excess weight loss compared to our white patients who underwent Roux-en-Y gastric bypass, but there wasn't differences in weight loss outcomes for those who underwent sleeve gastrectomy. So there may be something specific about the procedure type that is leading to this disparity. And this has been supported by other research as well. Another question that we had was perhaps it's psychological behaviors or eating behaviors that might be influencing poor weight loss outcomes after surgery. And so we wanted to take a look at this as well. And so amongst our patients who are presenting to the pre-surgical evaluation, during the pre-surgical psychological evaluation specifically, we wanted to see whether there were differences in anxiety, depression, and any sort of eating behaviors that we assessed, including emotional eating, food addiction, and binge eating. And we did find some differences. Specifically, white patients had higher levels of emotional eating specific to anger and frustration and depression compared to Black patients. And although not statistically significant, it was still trending in the direction for white patients having a higher Yale food addiction symptom count, as well as potentially higher anxiety symptoms. Again, although that was not statistically significant. So we did find racial differences, but it wasn't in the direction that we expected because more symptoms were reported amongst white patients. So unfortunately, this led to more questions rather than answers. Specifically, is it that these factors could be changing after surgery, leading to better weight loss outcomes? So perhaps our white patients had improvement or resolution in some of these symptoms, and which ultimately led them to have better weight loss outcomes. Alternatively, maybe we're not detecting these factors appropriately amongst Black patients. The measures that we're using were normed predominantly on white samples. And so perhaps there are cultural differences with psychological symptoms or eating behaviors that aren't being appropriately assessed by the measures that we're using. And so just kind of to conceptualize how all of these factors could be potentially influencing the disparities in utilization and weight loss amongst patients. I think there are patient factors, there are provider factors, and there are system level factors, some of which I talked about today, but there are many more that have been examined in the literature as well. So amongst patients for utilization, potentially finances are getting in the way. Maybe patients don't have the same body image across different cultures. There is other work that has been done too that suggests patients at higher BMIs or with greater physical burden are less likely to undergo surgery. Importance of weight loss might differ by race and culture. And there might be some biological factors among different races that are influencing post-surgical weight loss outcomes. On the provider level factors, this is a little bit more anecdotal. I think there's more work to be done here, but it's possible that providers might have some weight biases. They could also have some biases towards bariatric surgery themselves that could be influencing their referrals to bariatric surgery. And of course, there's some system level factors as well, including environment, insurance coverage, and there may also be some systemic racism at play in disparities too. I think there's a wide variety of areas for future directions. I think we can look at, again, these patient factors, and we do know that there are some psychosocial factors that could be influencing some finances, as well as potentially patient beliefs and attitudes. I think it would be interesting to see the strength of each of these in predicting utilization and weight loss outcomes. Again, I mentioned the provider factors. Potentially, we can better understand how providers choose who they refer. Maybe we need some interventions to help increase referrals. So that's an area of future research. I know Karen Coleman at Kaiser Permanente Southern California has a grant right now looking at environmental factors and healthcare system factors to promote better weight loss outcome after surgery. And biological factors, I think, could be explored further as well. I don't think there's enough evidence right now to make a recommendation for the type of surgery based on race. So although we did find that there wasn't that disparity there with sleeve gastrectomy, I think more research needs to be done before we start making recommendations based on race. So I would like to acknowledge all of my co-investigators, so Leah Hecht and Shannon Clark-Sinkovich, who are trainees with me, who helped lead some of this work, our bariatric psychologists, Kelly Martins and Erin Hammond, some of our bariatric surgeons, Art Carlin and Jeff Janah, many of our other research team members in the bariatric surgery program, and patients for whom without this research would have not been possible. So thank you all so much for your attention.
Thank you, everyone, for those excellent talks. Really interesting work. Now, I would like to announce and present the TOS Presidential Medals of Distinction from the Obesity Society. The TOS Presidential Medals of Distinction are given to individuals for their significant role in the understanding of the physiology of obesity, treatment, and care. This year, we have 3 winners, whom I will introduce in alphabetical order. I'm pleased to announce that the first awardee is Dr. Barbara Corky, whom most of you know. Dr. Corky is Emeritus Professor of Medicine and Biochemistry at Boston University School of Medicine. Dr. Corky's work focuses on the metabolic regulation of signal transduction and energy metabolism in fat cells, beta cells, hepatocytes, and human fibroblasts. She has been studying fuel-stimulated insulin secretion by the pancreatic beta cell, fuel partitioning in rat adipocytes, cytokine signaling, and calcium transients in human fibroblasts from patients with inborn errors of fatty acid oxidation and type 1 diabetes. Dr. Corky has also been heavily involved in TOS and its leadership over the years and is president in 2003 to 2004. Dr. Corky is being recognized for her excellence in basic science obesity research on metabolic regulation of adipocytes and for her dedication to and service in leadership of the Obesity Society. Congratulations, Dr. Corky.
Thank you. I'm deeply honored that you have chosen me for this award. TOS has been an important part of my research life for several decades. In fact, I've been engaged with this organization since the very second NASO meeting. As individuals and a group, we have led the battle to have obesity, the most prevalent disease in the country, recognized as a disease. Importantly, we continue the critical focus on the cause and the cure, and most importantly, the funding needed to reach our goals. I believe that we are engaged in addressing the most important health crisis of our time. I am very grateful to be part of this effort. Thank you very much for this great honor and for your work in continuing to address this major health crisis. Thank you.
Thank you, Dr. Corky. The next awardee is Dr. Shiriki Kumaniika. Dr. Kumaniika is part of the faculty at Drexel University and retains an appointment as an emeritus professor of epidemiology at the University of Pennsylvania. Dr. Kumaniika was vice chair of the Health and Human Services Secretary's Advisory Committee on Healthy People 2020 and was also involved in efforts to develop Healthy People 2030. Recently, Dr. Kumaniika served on the Diversity Task Force for the Obesity Society. Among her many other achievements, Shiriki was the founding chair of the Council on Black Health, formerly known as the African American Collaborative Obesity Research Network, which has helped to increase the presence and visibility of Black scholars in obesity research. Dr. Kumaniika's research is focused on solutions to obesity and diet-related diseases in Black children and adults, improving equity-focused obesity policies and programs, food and nutrition policies, evidence-based public health, implementation research in community settings, and system science applications in public health. Dr. Kumaniika is being awarded the TOS Presidential Medal for her excellence in national leadership in equity-focused obesity policies, implementation research, and public health obesity efforts. Congratulations, Dr. Kumaniika.
Thank you, Dr. Cox. This is truly an honor for me, especially since I joined TOS when it was NASO early in my career and used to walk around the annual meetings in awe of the prominent scholars I saw there. TOS has become my professional home and anchor point for research on obesity and keeping up with the field over more than 3 decades. It's provided me with opportunities to learn and enrich my own work, to become familiar to others in the field, to present my work and have it critiqued, and to mentor a range of diverse scholars. TOS has also been welcoming to me for service in areas that I have felt were very important to the organization, particularly advancing diversity, both gender and ethnic diversity, and also to bring attention to the disparities in obesity that affect populations of color, many populations of color, and that really still are not receiving enough attention. I'd also like to take this opportunity to thank the many colleagues and collaborators that I've met and worked with over the years within TOS and connected with at meetings. They're too numerous to mention here in these brief remarks, but I hope you know who you are and really know how much I have valued my interactions and friendships with you over the years. So in conclusion, I'd like to reiterate my thanks for receiving this honor. I'm deeply grateful for it. And to also thank the TOS community for all that you do to really try to address the challenges that we face in this field in science, policy, and practice.
Thank you, Dr. Kamaniika. Finally, I'd like to present a TOS Medal of Distinction to Dr. Xavier Pisanier. Dr. Pisanier is a professor of medicine at Columbia University's Institute of Human Nutrition, and he has been a leader in obesity medicine for more years than many of us have been around. He chaired the expert panel that published the clinical guidelines on the identification, evaluation, and treatment of overweight and obesity in adults in 1998. He has been a constant supporter of the Obesity Society and was involved in leadership in TOS from the early days and serving as president in 1994 to 1995. He has also served as president of the American Diabetes Association, the American Society for Clinical Nutrition, as well as counselor for the Society for Experimental Biology and Medicine. His research focus is on carbohydrate and lipid metabolism, obesity and diabetes, and among his many accomplishments is his work studying obesity physiology, developing new obesity therapies and their guidelines. He is also on the steering committee of the NIH-supported Diabetes Prevention Program, Look Ahead Trial, Life Moms Trial, and GRADE Trial. The Obesity Society elected to award Dr. Pisanier a TOS Medal of Distinction for his seminal contributions to obesity physiology and medicine, his important efforts on obesity guidelines, and his service and leadership for the Obesity Society. Congratulations, Dr. Pisanier.
I'm very honored to receive this award, and I thank you for giving it to me. Over the years in my career, I have relied on many colleagues, and I'd just like to mention a few of them here: Dr. Van Italy, Harry Kiselev, Janine Albu, Joe Vaselli, Blondine Laferrere, Dipna Gallagher, and Rudy Leibel. Without them, my career would have been very different. It was through their steadfast help and collaboration that we were able to accomplish as much as we did. When I first turned my attention to obesity many years ago, very few researchers were involved. But obesity was exploding in the United States and languishing for attention. We have learned a very great deal since that time. And the Obesity Society has led the way in many ways, lobbying for better care and coverage, lobbying for clinical support, and lobbying for research support. It's been a pleasure for me to be a member of the Obesity Society, where I have made great friends and colleagues. I also want to thank all our patients. We worked in clinical research, and without the persons with obesity who helped us along the way, we could not have done what we did. So thank you again for a wonderful honor. I really do appreciate it. Thank you.
Hello again. I hope you enjoyed those hot topic talks, which were excellent. Thank you for staying around for this session, which is going to be a short talk of my work on spontaneous physical activity and its role in body weight regulation in animal models. Through production of ATP, physical activity increases energy expenditure. The more intense, the more ATP production. The role of physical activity in losing weight is somewhat controversial, but we do know that when physical activity programs are adhered to, they can reduce weight and prevent weight regain. Adherence can be difficult for many, exercise programs, but this talk will be about the potential for non-exercise physical activity. Spontaneous physical activity in humans is all non-exercise activity, such as standing, moving about, fidgeting, and other non-exercise physical activity events. In other words, all physical activity that cannot be characterized as exercise. In animals, we define spontaneous physical activity as all activity in the home cage that does not involve exercise events. So essentially, activity in cages that do not include running wheels or other objects that would motivate an exercise event. The term non-exercise activity thermogenesis refers solely to the kilocalories produced by spontaneous physical activity. The energy budget in humans has undergone various revisions over the years in how the categories are defined and how the categories can be adapted. This is the energy budget in humans as described in a review by Ed Melanson in 2017. As you can see, resting metabolic rate comprises most of the total daily energy expenditure, and then there's a small portion devoted to the thermic effect of food, exercise, non-exercise physical activity, and then other energy expenditure events that do not fit into those categories. I like this version because it points out the components of this energy expenditure that can be considered adaptable, which includes non-exercise physical activity, or NEAT, which is the component that I'm going to focus on today. This slide shows data from a very recent paper out of John Speakman's group that I think is quite important. This paper was a compilation of double-labeled water data from many different studies with a total data set from around 1,700 individuals living normal lives. The goal of the study was to understand variation in daily energy expenditure and to address the issue that many report, and which other studies suggest, of not gaining the caloric advantage that many energy models would predict for activity thermogenesis. It's been long suspected that there may be a compensation of sorts for large bouts of physical activity, and that not all individuals receive the same caloric benefit from physical activity. The authors of this study used this large data set to fit energy expenditure data to best reflect the relationship between daily basal and activity energy expenditure. Due to the nature of the data collection, total daily energy expenditure could only be divided into these two categories. The graph on the far left shows the compensation model, which suggests that when there are increases in activity thermogenesis, basal energy expenditure is reduced such that total daily energy expenditure does not change. Rather, the calories produced from basal energy expenditure are reduced and essentially reflect an energy expenditure set point. The mechanism underlying this compensation is unclear, but one potential idea is that intense exercise bouts may induce more compensation than low-level physical activity. The focus of my work is on NEAT, which is by definition related to low-level physical activity. If there are ways to modify NEAT such that compensation is minimized or at least reduced, we may be able to improve energy expenditure outcomes. One final note about the study is that the degree of energy compensation varied between people of different body compositions. Individuals who were lean compensated less, while individuals with obesity compensated more. This may explain many other findings related to energy expenditure in obesity and why individuals with obesity may not incur the same advantages through exercise as those who are lean. A goal of our work is to understand how NEAT is regulated and potentially modifying it to make it easier for individuals to be physically active, to help with weight gain prevention and weight loss maintenance. Our main question is, can we develop therapies to help people be more physically active throughout the day? To study this, we need variability in subjects, and in our lab, we work with animal models. These data show that mice have variation in individual propensity for physical activity, measured by beam breaks during the dark or active phase. So just like humans, there's high variability in physical activity levels in mice, which is an advantage when we want to study these outcomes. We also knew of an important animal model of obesity, which are the obesity-prone and resistant rats, originally developed by Dr. Barry Levin. As you can see on the left, these rats at 6 weeks old do not look different from each other, whereas a year later in the picture on the right, you can see the body weight difference between the two animals, despite that these rats were kept in the same cages with the exact same food access and no running wheel. These rats were originally developed for their response to a high-fat diet, but in our studies, we did not use a high-fat diet. So the question is, what are the behavioral characteristics that cause such a difference in body weight? We suspected it could be differences in spontaneous physical activity. So in our first studies, we looked at time spent moving when placed in a beam break cage that measures their movements in all directions. Our beam break data were collected every 50 milliseconds, and through that, we determined time spent moving in these animals. We then put 4 sets of rats into these cages: obesity-prone rats with and without food, and obesity-resistant rats with and without food, since we suspected that food in the cage might influence their physical activity. On the bottom is the 24-hour cycle, and the dark cycle starts where the gray bar starts. All the rats started moving when the dark cycle started, since they are nocturnal, and that is their high activity time of day. On the top 2 lines are the data from obesity-resistant animals, and the bottom 2 lines reflect data from the obesity-prone animals. You can see the large difference in spontaneous physical activity over 24 hours, and food in the cage reduced this activity somewhat in both sets of animals. We did several follow-up studies that I don't have time to show today, but the physical activity in obesity-resistant animals was due to increased moving events for longer periods of time. They do not move with a higher velocity, but rather this is natural movement about the cage. At this time, we were also studying the neuropeptide orexin, also known as hypocretin. This neuropeptide was discovered in 1998 by 2 groups, and hence the 2 names. Orexin is synthesized in the lateral hypothalamus, but has widespread projections throughout the brain. We were doing feeding studies with these animals at that time, and my graduate student noted that when orexin was injected into the hypothalamus, the animals moved about the cage more often and for a longer period. We made the connection then that perhaps orexin could be mediating spontaneous physical activity. To test this idea, one of our first studies was to determine the orexin tone in obesity-prone and resistant rats. We measured orexin receptor levels in various parts of the brain and show that obesity-resistant rats have a much higher orexin receptor expression level. And as you can see in the graph on the right, the obesity-resistant animals throughout their lifetime have a much lower level of body fat. The inset slide shows that the obesity-resistant rats had much higher levels of spontaneous physical activity throughout the study. Follow-up studies on this relationship between orexin and obesity resistance all point to the same relationship. The next goal was to determine whether orexin-mediated physical activity could be modified. To do this, we used the orexin receptor antagonist, SB 334867, and infused it into brain using mini pumps attached to cannula directed to a hypothalamic site of action for 7 days. On day 3, we did a 24-hour measurement of physical activity. As you can see, light cycle behavior was not different between groups, whereas in the dark cycle, the time in which the animals are most active, the obesity-resistant rats receiving the orexin antagonist had reduced physical activity. We did many more follow-up studies, which all indicated that spontaneous physical activity is a regulated and modifiable behavior. To study this from a different angle, we characterized 24-hour spontaneous physical activity levels in a large cohort of standard laboratory Sprague-Dawley rats. The histogram shows that there are many rats in the middle category, but in our follow-up work, we excluded those rats and just looked at the extremes, either low or high activity rats. This slide shows that the high activity rats, by definition, have higher intrinsic spontaneous physical activity, but importantly, these animals also have higher levels of orexin expression, again, pointing to the relationship that orexin drives spontaneous physical activity. So it's all well and good that we found this relationship, but our real goal was to determine whether orexin could in fact prevent adiposity gain. To this end, we gave rats a high-fat diet for 10 days. We had an additional group that received 1 orexin injection per day and then a control low-fat diet group. As most of you know, rats on a high-fat diet love the diet and they gain weight very quickly. In the graph on the left, you can see that the high-fat diet increased food intake in both orexin and sham-injected animals. The far right graph shows the adiposity index. As you can see from that graph, animals on the high-fat diet had a much higher adiposity index than controls, whereas the adiposity index of the animals given high-fat diet plus orexin remained at the same adiposity index as the control animals. These data were really exciting to us as they showed proof of concept that orexin could mitigate weight gain. There are several other animal models of gain and loss of function of orexin and obesity that support these findings, but I don't have time to go through them today. One methodology aspect of all of our studies that I've shown so far is that the approaches were all direct injection into brain, and we wanted to try a new approach that does not involve direct brain injections. To do this, we adopted the DREADS approach, which is short for designer receptors exclusively activated by designer drugs. These are modified G protein coupled receptors that recognize a designer drug. You can place these modified G protein coupled receptors onto your cells of interest. There are several different designer drugs, but we are currently using CNO or clozapine oxide. Using molecular genetics paired with breeding approaches, we were able to insert the designer receptors into orexin neurons in living mice. This, coupled with an open indirect calorimetry system, provided for remote activation of orexin neurons. In our first study using this approach, we injected the designer drug, CNO, peripherally into the animals, and you can see in the upper graph that this increases spontaneous physical activity in both male and female rats without influencing eating behavior. The graph on the bottom shows that this increased SPA is associated with increases in energy expenditure or NEAT. In a follow-up study with the same approach, we showed that remote activation of orexin neurons prevented weight gain. As you can see in the left-hand figure, the change in body weight of the two groups, both on high-fat diet, one with vehicle injection and one with a designer drug injection, that there's a significant prevention of weight gain with this approach. The graph on the right-hand side shows the adiposity index. Like the study in rats, you can see that the high-fat diet was effective at increasing the adiposity index, and the DREAD approach mitigated that significantly, though not completely. We are currently undertaking additional studies to determine whether we can use another strategy to get a more robust response with this approach. Now, shifting gears slightly, we know that during aging, there is often weight gain. A review of both human and animal literature indicates that this is preceded by reductions in brain orexin expression and spontaneous physical activity. We wanted to determine whether we could alter this aging profile of body weight gain using the DREAD approach in mice. As this slide will show, we were able to reverse aging-induced reductions in SPA and NEAT. This figure shows the 24-hour light dart cycle in young and old animals that either receive CNO stimulation of orexin neurons or not. In this study, CNO was given in the drinking water, in part to reduce behavioral disturbances produced by injections. If you look at the upper SPA graph first, you can see the levels of SPA in the young animals on the left, and to the right of that group is the SPA level in the older animals, which is significantly reduced. On the far right-hand side of that same graph are both the young and older animals treated with CNO. You can see that CNO increased SPA levels in the young animals somewhat, but importantly, the SPA level in the older animals is now very similar to the SPA level in the young animals. So we can say with these data that orexin stimulation restored aging-induced reductions in SPA. Below are the same categories and treatment groups, except here we are looking at energy expenditure. You can see that the same pattern here in that the young animals have higher NEAT levels relative to their older counterparts. The data on the bottom right-hand side show that older animals treated with CNO show similar NEAT levels as their younger control counterparts. For us, these are really exciting data given the conceptual potential to reduce age-related declines in physical activity and NEAT. Finally, my last data slide shows some new work with a novel orexin agonist developed by my collaborator, Dr. Yanan Zhang at Research Triangle Institute. We recently did a small study with this new agonist, and as you can see here, it increases SPA after peripheral injection in mice, a fairly robust effect. We're doing follow-up studies with this and other agonists as these provide better translational potential for future work. So the take-home messages are that there is circuitry underlying spontaneous physical activity and NEAT, and that this appears to be a regulated behavior. There are several studies I have not shown you that suggest underlying circuitry responsible for spontaneous physical activity, which is shown in the figure on the bottom, the cartoon figure on the bottom, which is a description or a characterization of all the areas in which we've looked at orexin and its effects on physical activity. The second message is that, take-home message is that the drive to move is initiated by brain centers and therefore could be therapeutically enhanced. And that is something I think we really should be looking into more. So future directions really are to determine if manipulation of NEAT can change the energy compensation model to one of an additive model so that weight change and maintenance is easier, and to explore other brain-based therapies to nudge increases in NEAT to improve healthy weight maintenance. Other investigators have noted neurotransmitters and neuropeptides involved in physical activity, including Gina Leininger, Colleen Novak, and many others. And my point there is to say that I think it is useful to have additional targets. And if we did similar studies with some of those neurotransmitters, I think we might find similar results. With that, I will end, but I wanted to indicate that there are some additional related sessions. There's the Blackburn session this evening that will discuss physical inactivity and the metabolic response, and I hope you can attend that. And then there is the joint symposium between TOS and the American College of Sports Medicine that will be an overview of the molecular transducers of physical activity, which I'm really looking forward to. I'd like to also thank the funding sources for these studies, the U.S. Department of Veterans Affairs and the NIH, and all the lab members that put work into these studies. These folks have been integral to our laboratory research program, and without them, none of this work would have occurred. Many of them have moved on to different positions around the country and have their own research programs, but I owe them a large debt of gratitude for their contribution to the work I presented today. I've been honored to be the TOS president. It is something I aspired to, as TOS has been my academic home throughout my career. I've tried to do good work for the society in the last 3 years, and as I wrap up my TOS presidency, I would also like to thank all the members of the TOS staff that I've come to know, including Tony Camuzzi, Regina Williams, Anita Weiler, Darnella Parks, Chanel Carrington, Robin Gordon, Shamika Green, Christy Turner, and Allison Template. For relatively small office staff, they produce a large amount of excellent work, and I'm impressed by each of them. I'd also like to thank the members of the executive committee for their guidance as I came into this role. First, Caroline Apovian and Steve Heimsfeld for their wise advice, and the immediate past president, Lee Kaplan, who has been an excellent mentor for me. All of the work of these predecessors left TOS in good shape to allow me to do many things for the organization this year. I've also learned a lot from Leah Wiggum, our secretary-treasurer, and Dan Bessison and Elizabeth Parks, who will follow me behind me in this role. I really enjoy working with all these individuals, and they've been incredibly helpful to me this last year. I've learned so much from all of them and feel honored to have gotten to know them so well. I look forward to my upcoming year as immediate past president and will continue to serve the Obesity Society in that role. Finally, I would like to thank my personal support crew for helping me throughout this busy time. My mom and dad, my husband Mike, for helping me in so many ways and tolerating some long work hours. My 2 children and 2 wonderful granddaughters who have blessed my life. And I also have a grandson arriving any day now, so my support crew is growing in wonderful ways. In closing, I would like to thank all of you for being here. I hope you enjoy the meeting. I think it's a really excellent program. Hopefully I will see you in some of the discussion boards and chat rooms. And also feel free to contact me if you have any questions about any aspect of the work I presented today. Enjoy the meeting.